faithfully delivering value, interpreting great books from around the world. Hi, this is Sally's Book Talk. Today, we're diving into the book Open Heart, subtitled Life and Death Stories from a Heart Surgeon's Operating Table. The author, Stephen Westoby, works at Oxford's John Radcliffe Hospital in the UK, and he's a world-class expert in heart surgery and artificial hearts. Westoby was born into an ordinary working-class family in Britain. When he was 7, his beloved granddad passed away from heart disease, which made him vow to become a life-saving doctor. And to chase that dream, in his teens, he took a part-time job as a hospital porter. Other porters just handled the heavy lifting, but he used the chance to pick up loads of skills. For instance, he'd adjust the operating lights based on the day's surgery schedule. He even pestered pathologists to let him watch autopsies, and amazingly fast, he mastered the detailed anatomy of the human body. His incredible talent and hard work got him into med school and eventually made him a heart surgeon. On the heart surgery table, he spent a solid 50 years, took part in over 10,000 heart ops, opened more than 12,000 hearts, and saved many critically ill patients' lives. Among these patients, lots had already said their final goodbyes to family before being wheeled into the OR. This book is Dr. Westoby's career memoir. In it, he weaves his whole career through over a dozen gripping surgical tales. His entire journey not only lets us feel firsthand the dilemmas and challenges a heart surgeon faces, plus his passion for the job and awe for life, but also makes us rethink the value of medicine and life through doctor-patient stories. And we all know the heart's the most vital organ. When it stops, blood and oxygen can't reach the body, and life can end in 5 minutes. So, unlike regular surgery, heart surgery is a super tough, high-risk profession with life or death stakes. Next up, let's step into a heart surgeon's life at the operating table and see what unique problems and challenges they encounter. And how do they handle them? The first challenge heart surgeons face is racing against the clock. Because patients with sudden acute heart attacks are usually in critical condition, doctors need to make quick, accurate judgments and provide immediate rescue. For example, myocardial infarction, which is a common heart disease, happens when the coronary artery supplying blood to the heart gets blocked, causing the heart muscle to die from lack of blood. If a heart attack patient gets proper treatment within 40 minutes of chest pain, there's a 60 to 70% chance of saving their life. But if treatment is delayed beyond 3 hours, the patient's chance of survival drops to just 10%. Westoby mentions in his book a case of massive myocardial infarction. The patient, named Clark, had entered what's medically called cardiogenic shock. His blood pressure was only half of normal. Lactic acid built up in his blood, froth oozed from his mouth, his eyes rolled back. He was near death. At that moment, Westoby had just finished a full day of surgery and happened to pass the ward. After learning the situation, he immediately decided to add an emergency operation. All right, I know myself. With no time to wait for porters, Westoby and a nurse pushed the patient into the elevator themselves. After 3 hours of resuscitation, Clark finally pulled through. But 6 months later, Clark's brother had the same thing happen. Because he didn't get timely treatment, he died, shattering what was once a happy family. In cardiac surgery, time is life. To save patients to the greatest extent, heart surgeons must race against time. Westoby often got calls late at night saying a patient was dying and needed surgery immediately. He'd jump up from beside his sleeping family, hit the gas pedal hard, and speed all the way to the hospital, getting pulled over by police several times for speeding and running red lights. Westoby also died. Eventually, the police got fed up and said, "Next time you're in such an emergency, just call us, we'll come pick you up." Another time, Westoby was vacationing with his family in Australia. In the middle of the night, in a hotel bed, he got a call from a UK hospital saying a baby with a rare congenital heart defect was in heart failure and might not make it, asking if he could come perform the surgery. Without a second thought, Westoby replied, "Schedule the surgery for tomorrow, no matter how late." And he actually flew back from Australia that same day. The surgical plan was drafted on the plane. After getting off the plane, he didn't even bother with jet lag. He immediately called the team to prep for the surgery. Besides sudden cardiac emergencies, the rate of post-op complications in heart surgery is higher than in other surgeries. And this is because traditional open heart surgery is highly invasive. During the procedure, the heart is stopped, cutting off its blood supply, which weakens it. Plus, it involves complex vascular connections and sometimes implants like artificial hearts. So, even if the surgery is successful, it doesn't guarantee the patient will survive. It also depends on whether the patient can safely get through the critical post-op period and avoid common complications. Now, for instance, a stroke or unexplained cardiac fibrillation, where the heart stops beating regularly and suddenly trembles irregularly, can directly threaten the patient's life. And if immediate, effective treatment isn't available on site, the patient may still die tragically. Westoby recounts an example in his book. He just operated on a baby with congenital heart defects and was supposed to stay in the ICU. But the ER suddenly brought in the patient with severe heart injuries from a high-speed crash, so Westoby had to prioritize that emergency case. And that was idle alone. Mae Westoby is dead. Unfortunately, that baby did develop complications. His heart suddenly went into fibrillation. But the young doctor on site didn't know how to handle it properly. By the time Westoby finished his surgery and arrived, it was too late. Westoby knew very well that for a critically ill heart patient, survival largely depends on having an experienced doctor nearby and receiving correct, timely treatment. Therefore, he seizes every opportunity that comes his way. In the 1970s and 80s, when cardiac surgery was just emerging, new technologies and equipment gradually appeared, giving many heart patients who previously had no hope a new lease on life. Back then, as a young doctor, Westoby worked almost non-stop in the hospital, doing surgeries all day and keeping vigil in the ICU at night. He said, "I always leave the hospital reluctantly because I don't want to miss anything important." And that's such work intensity indeed earned him brilliant achievements in his profession. But it also cost him dearly. When his daughter was born, he was guarding other infants in the intensive care unit. Every soccer match during his son's middle school years, he was either on the operating table or rushing to the hospital, filled with guilt towards his family. I spent a lot of time trying to save other people's children, but never had enough time for my own because he valued work too much and neglected his family, leading to the sad end of his first marriage. And sometimes seeing heartwarming scenes of recovered patients with their families, Westoby would feel deep loneliness and longing in his heart. But the next second, as soon as he saw an ambulance arrive or heard a patient groan, he'd still clear his mind instantly and rush to treat them without hesitation. Besides racing against time, the second challenge heart surgeons face is the critical condition of patients, which requires doctors to have unwavering determination not to give up until the very end. And that is Leeds Long Brady. Facing critically ill patients, the doctor's decision is crucial. If the doctor gives up on resuscitation, the patient has no choice but death. If the doctor persists in treatment, they might still have a slim chance of survival. But it's not easy for doctors to decide whether to treat or not, because heart surgery carries huge risks. The patient might die on the operating table, plus post-op complications mean, even with surgery, survival isn't guaranteed. In such moments, for a doctor to insist on treatment requires immense courage. The book mentions a critical case. A patient named Anna had a common heart myxoma. It's a benign tumor that can cause stroke. Unfortunately, Anna suffered a stroke and became paralyzed because of it. What's worse, after removal, most myxomas don't grow back. But Anna had recurrences 5 times over 10 years. When it recurred for the fifth time, whether to operate or not was a true dilemma. Without surgery, Anna would die soon from cardiac obstruction, but she could still enjoy some final time with her family before that. If surgery continued, the consequences were dire because Anna was paralyzed, her health worsened from previous surgical trauma, and she was highly likely to die on the operating table. Most importantly, this surgery had a low success rate, as shown by the results of the previous 4 operations. All doctors present felt it was unnecessary to operate again, and rather than subjecting the patient to more suffering, perhaps accepting fate was better for her. Westaby first asked Anna's family what they planned to do. They said they'd rather Anna die in the operating room than be abandoned by doctors. So Westaby decided he wouldn't give up either. Anna? Fortunately, over 10 years after that 5th surgery, Anna is miraculously still alive. They brought Westaby a homemade cake, thanking the doctor for not giving up on her. Another critical situation happens during surgery. When the original plan fails, all rescue attempts prove useless, and the patient seems beyond saving. Can doctors still persist then? Among all heart diseases, congenital heart defects are the most troublesome. Their complexity often exceeds doctors' expectations, and most patients are infant girls. Curtis had a rare congenital heart disease. It has a long, complicated name, anomalous origin of the left coronary artery from the pulmonary artery. Simply put, the heart's blood vessels are wired wrong. This caused Curtis to suffer repeated agonizing heart attacks over months. Her heart gradually failed, life fading fast. Regular doctors couldn't handle such complexity, so they passed the challenge to Westaby, but the surgery didn't go smoothly. Though Westaby executed the meticulously planned surgery nearly perfectly, that tiny heart just wouldn't resume normal rhythm. No matter what measures doctors tried, nothing improved. Everyone present thought the baby couldn't be saved. Someone already went to tell Curtis's parents to prepare for the worst.
As lead surgeon, Westaby's palms were drenched in cold sweat.
But he still refused to give up, never surrender. This was Churchill's motto, and the professional creed Westaby always upheld. Under everyone's astonished gaze, he picked up the scalpel again and began trying a new approach.
Astonishingly, Curtis was saved, a tiny life on death's doorstep revived by the doctor's persistence.
When Westaby wrote this book, Curtis had already celebrated her 18th birthday. On her 18th birthday, she was a beautiful, lively young woman. Then there's an even more complex scenario, when saving a critical patient requires taking extreme risks, even breaking laws and gambling your career. How many can bear that cost? The book recounts this example. Young trainee teacher Julie was dying of heart failure due to severe viral myocarditis. Other doctors called Westaby, asking if he had any life-saving new devices, but added it didn't matter since Julie had just said her final goodbyes to family. In cardiac surgery, assist devices are crucial, like in traditional open heart surgery, where the heart must be stopped, cutting off its blood supply. Doctors typically use a machine called a heart-lung bypass to supply blood and oxygen to other tissues during this time. However, bypass machines can't be used long-term as they risk causing body-wide inflammation. If heart function doesn't recover post-op, we must rely on other assist devices that work longer. Though varied, these devices are essentially artificial hearts that temporarily replace the heart's pumping function, maintaining blood and oxygen supply. For heart failure patients, doctors often use a balloon pump device. But Julie was too sick. The balloon pump failed completely and even blocked blood flow to her legs. Thus, Julie desperately needed a new life-saving device. Westaby happened to have a trial machine called AB-1800 for research purposes. But this was no ordinary machine. It was a non-pulsatile artificial heart. What does that mean?
Before this, doctors believed blood flow required a pulsing heart. No pulse meant no life. This non-pulsatile heart used a turbine instead of traditional pulsation to create continuous blood flow.
If implanted, the patient would have no pulse or blood pressure, an unthinkable concept at the time. Because of this, the AB 180 wasn't approved by UK medical authorities. In other words, any doctor using it on a patient would be breaking the law. You might ask, weren't there other legal devices available? Absolutely none. At that time, artificial hearts were cutting-edge tech. Many devices were just entering global clinical trials and hadn't been approved in the UK. Even devices that were approved weren't available in every hospital. For example, the book mentions a relatively advanced machine at the time called ECMO, extracorporeal membrane oxygenation, suitable for patients with combined heart and lung failure. In the UK, only the National Transplant Center had this equipment. Other hospitals had to go through great trouble to borrow it or simply transfer patients to the transplant center.
But Julie couldn't wait or endure transfers. Facing a dying patient, follow rules and watch her die, or cross legal boundaries to save a life.
Westoby chose the latter without hesitation.
He said, "Since I became a doctor, I won't let young patients die because of administrative issues." Westoby's daring gamble saved Julie's life and proved continuous blood flow without pulse or blood pressure could sustain life. A major medical breakthrough. After Julie's surgery, Westoby was warned by the medical director, "Do this again, and you're fired." But Westoby clearly didn't listen and soon repeated the act.
3 weeks after Julie's surgery to save Stefan, a boy with viral myocarditis, he scrounged up another unlicensed blood pump. Only this pump suited a 10-year-old child. This pump also saved Stefan's life at the last moment and sustained him through the grueling wait for a heart transplant. Westoby said, "I can't just watch patients die. I firmly believe saving lives is always ethical, no matter the cost." Beyond urgency and severity, the third challenge for heart surgeons is vast patient variability. So even with the same heart disease, each patient needs unique treatment and surgical plans. Take viral myocarditis. Julie had acute infection. Inflammation and fluid buildup destroyed her heart function in just 1 week. But Stefan's viral myocarditis developed over months before causing heart failure. Because she was sick for such a short time, Julie's heart suffered much less damage. So after using the AB 180 for a while, her own heart recovered and the device could be removed. But Stefan's heart was damaged for too long to recover on its own, so he ended up needing a heart transplant from someone else. Moreover, individual differences often complicate routine cases, increasing surgical and treatment difficulty. Saving such patients requires not just technical expertise, but innovative spirit and courage to explore new approaches. The book shares an example. Westoby once treated an 18-month-old boy dying from a congenital heart tumor blocking his vessels. Normally, this benign tumor would have been straightforward to remove with routine surgery,
But this boy had an extremely rare dextrocardia.
meaning his heart was on the right side of his chest, a case most doctors never encounter in their careers. Operating on a reversed heart forces surgeons to think and act in mirror image to normal procedures. Like being right-handed suddenly forced to use your left hand, awkward and uncomfortable. Plus, standard surgical tools are designed for normal heart placement, making it even harder. For Westoby, this presented a completely new challenge. The surgical solution came from a flash of insight after intense contemplation. Innovative, risky approach. Westoby removed the boy's heart and placed it on a workbench, like in transplant surgery, to operate without the disorienting positioning.
Though extremely high risk, it was the only life-saving option available. Finally, the tumor was removed, the heart stitched back, restarted, and a little life saved by the doctor's bold innovation.
Another example, Julia with congenital aortic valve stenosis. The aortic valve sits between left ventricle and aorta. Stenosis blocks smooth blood flow. Normally routine, just requiring artificial valve replacement surgery. But Julia's unique situation complicated things. She was 40 and 12 weeks pregnant. Although a congenital condition, Julia had never experienced any discomfort in her first 40 years. Symptoms emerged due to increased cardiac blood flow during pregnancy. When diagnosed, her condition was critical. Without immediate surgery, she might only have weeks left. The safest conventional approach was abortion first, followed by heart surgery and artificial valve replacement. But at 40, driven by maternal instinct and fear she might not conceive again, Julia insisted on keeping the baby. This was extremely dangerous. No surgeon would operate on an aortic valve during pregnancy. One mistake could kill both mother and child. After thorough discussion, Westoby and colleagues chose to respect the patient's wishes. To maximize success, Westoby designed an ultra-detailed personalized plan minimizing fetal risk during surgery. For instance, they elevated blood pressure and increased flow speed during surgery to prevent placental vessel constriction. Cardioplegia solution protected the heart muscle but required strict dosage control to avoid harming the fetus. Fetal heart rate and uterine contractions were monitored throughout, with immediate intervention if needed. And Westoby's efforts succeeded. The valve replacement during pregnancy worked. 5 months later, Julia delivered a healthy baby boy. Such innovations defined Westoby's career, from sewing human aorta segments during cannulation for elasticity to shrinking infant hearts. In highly individualized cases, these mind-blowing maneuvers were commonplace. As he said, doctors must think proactively or leave this high-risk field. He called himself an obsessive surgeon, unable to resist solving problems. But behind that obsession lay a doctor's duty and resolve to save lives at all costs. Yet, the greatest challenge for heart surgeons comes from within: empathy for patients. For a doctor, empathy means truly feeling the pain of patients and their families. You might think empathy is essential for a good doctor, but for heart surgeons, it's different. Often they need to shed empathy. Why? Partly because hearts carry extraordinary meaning. Though science shows it's just a blood-pumping organ, many still see it as holding emotion and soul. Operating on this organ, doing transplants, even replacing it with a metal artificial heart, requires not just courage, but sometimes self-hypnosis. Also, daily facing life and death situations, empathy can bring unbearable pain, even paralyzing their courage for the next surgery. Westoby's first solo surgery came when his mentor rushed to an emergency case. But when he cut the sternum, disaster struck. The right ventricle tore open, bleeding uncontrollably. This patient had prior heart surgery. Inflammation fused the heart to surrounding tissues, a detail the mentor missed in haste. Without skilled assistance, the patient would have died on the table. Though not clearly his fault, Westoby was devastated. Waiting in ICU, he wondered if he'd quit surgery if the patient didn't wake. Then there was Stefan, the 10-year-old boy. As mentioned earlier, Westoby saved him with an unlicensed blood pump. Stefan eventually got a donor heart. But before that, no equipment, no matching heart. His young life hung by a thread. In that gloom, Westoby thought of his own children. What if this were my child? He hated feeling powerless, trapped in a whirlpool of grief he couldn't escape. Another patient, Alice, a college student, died on the operating table due to delayed equipment. Yet her family didn't blame Westoby, but thanked him for his efforts. They agreed to donate Alice's organs. They invited Westoby to Alice's graduation ceremony, where she'd receive a posthumous degree as a lasting tribute. That day, my heart was torn apart. Westoby said, "Leaving, I was shattered, like the whole world crushed my shoulders." Thus, heart surgeons must often shed empathy, distancing from sorrow and pain to fully focus on their work. So how do they shed empathy? Westoby's first method? Surprisingly, alcohol. In Westoby's early days, moderate alcohol was heart surgeons' go-to for unwinding. This was especially evident during night emergencies. Westoby rarely drank. It clouded his focus, but he understood. He knew the agony of facing relentless death. The second method, walk away quickly. Detach before sorrow consumes you. Dr. Ache, Westoby's colleague, often used this approach. At Stefan's bedside, no matching donor heart, the boy's life fading minute by minute. While Westoby drowned in grief, Dr. Ache silently left to continue rounds in other wards. Not coldness, avoiding futile emotional exhaustion. Especially after surgical failures, this emotional distancing becomes vital. The book shares this. During medical school, Westoby witnessed a failed surgery. A 26-year-old woman, recently postpartum, died tragically on the table. Westoby felt crushing sorrow, but the surgeon and nurse's next move stunned him. After silently handling the aftermath, they swiftly left the OR. Next, nurses come in, efficiently to clean up, sterilize instruments, wipe blood off the deceased, dress them in burial clothes, and quickly exit. After porters take the body away, they return to prep for the next surgery, all done in minutes with no delay or hesitation.
Because this OR still needs to save other patients. This woman is already gone.
But the patients after her still have hope to pull through.
What they need are calm, rational saviors, not a bunch of fools drowning in grief or regret.
And for Westoby, another way to ditch empathy is to tackle problems at the root, doing whatever it takes to save lives and end suffering. Westoby's story wraps up now. For most rational folks, cutting open a chest, stopping the heart, slicing and fixing it, that's a brutal job. Westoby has to do this day in, day out. At the book's end, he says the real stars are his patients. His life's got its own path and no human can bend it. Even if docs give their all, some patients still won't make it. Patients walking into the OR choose courage. All right, that's it for our dive into Open Heart. Listening notes are below the audio. See you tomorrow. Okay.